This program is brought to you by Emory University.
Good morning, everybody. Welcome to Friday Morning Fellows Conference, our second to last, I believe, of the year and our last journal club of the year. Maya and Anurag are going to be our presenters this morning. So first up is Maya Dassanayake. She is a second-year fellow in our clinical track from Michigan, med school at Wayne State, did a residency at the University of Michigan, and she will be at Grady next year as one of our chief fellows. And she is going to talk to us today about the TOMAHAWK trial from the New England Journal. Maya.
Awesome. Thanks for the intro, Dr. Williams. And so as he said, I'm going to be talking about the TOMAHAWK trial, which really looked at the timing of cath after patients with cardiac arrest. But before I start talking about the trial itself, I just want to go through some of the background studies leading up to this trial. So a lot of the initial data really came from registries. So in 2014, there were some studies before this too, but some of the more significant ones included a retrospective observational study from 2014, where they looked at 754 comatose patients treated with targeted temperature management. And they noted there that early angiography for out-of-hospital arrest patients without STEMI was associated with a decreased mortality. Then in 2015, they had a lot of the major targeted temperature management trials looking at DO equal to 33 versus 36. And they did a post-hoc observational analysis from that trial using 544 patients that this actually showed that early angiography was without STEMI was not associated with improved survival. So initially some conflicting data. Then one of the other big registries from 2016, the PROCAT2, was a prospective study of 695 patients where they found that emergent PCI in these patients was associated with what they called a favorable outcome. So nearly a twofold increase in higher cerebral performance scale measures. They also found that about a third of patients with out-of-hospital arrest without STEMI had a culprit lesion on their cath. So I also wanted to mention a paper written by Dr. Rabb and with input from Dr. McDaniel and Dr. Dickert that really looked at, they basically proposed a treatment algorithm for emergent cath in post-cardiac arrest patients who were comatose. And I won't go into it in too much detail, but basically their algorithm really had these two major branch points, whether the patients had STEMI on their EKG or no STEMI on their EKG. And of course, STEMI, there's good data and guidelines to suggest that we should go to emergent angiography, but they really advocated that for patients who did not have STEMI on their EKG, that we should kind of pause and look at what are the features of their resuscitation that may either warrant early angiography or just kind of taking time to see if they would even benefit from that. So then that actually brings us to 2019, where the COAC trial was the first randomized study to really look at this. And basically their conclusion was that immediate angiography was not superior to delayed angiography in patients with out-of-hospital arrest without STEMI, but they did only look at patients with a shockable rhythm, and the major endpoint was 90-day survival for their primary endpoint. Then they also looked at the COAC trial, the outcomes at 1 year, just in 2020, where similar results. They didn't see any improvement in 1 year outcomes for patients who had an immediate angiography strategy compared to a delayed strategy. And interestingly, unlike some of the prior data that suggested that a third of these patients have a culprit lesion, in COAC, they really found only 5% of patients that they looked at did have a true thrombotic lesion on angiography. And so that brings us to the study that I want to talk about today. This was the TOMAHAWK trial looking at angiography after out-of-hospital cardiac arrest without ST segment elevations. And this was published in the New England Journal, as you can see, in December this past year. So the objective of this study was to look at immediate coronary angiography with possible revascularization versus a more deferred or selective approach. So not all of the patients in that second group would go for cath. And their primary endpoint was looking at 30-day all-cause mortality in resuscitated patients with out-of-hospital arrest without STEMI. So, as I mentioned, this was a randomized trial. It was across multiple centers and international. They did keep it an open label trial, so meaning the physicians and ICU providers actually knew the which treatment arm their patients were randomized to. And this flowchart just kind of shows the what happened with at each stage of the study and the trial for them. So they initially considered 558 patients for inclusion. 4 were actually left out of the randomization just due to lack of informed consent. They had 554 patients that were ultimately randomized, with 281 going to the immediate angiography group and 273 patients going to the delayed or selective group. Now, out of those 2 groups, they analyzed 112 patients in an interim analysis and 110 patients in the delayed group for the interim analysis. And that initial part of the study was to really adequately power them for the final analysis. So they found that analyzing 265 patients in the immediate group and 265 in the delayed group would adequately power to about 80%. And in terms of the inclusion criteria, they looked at patients that were at least 30 years of age that had had out-of-hospital arrest with return of spontaneous circulation without STEMI on their follow-up EKG. And unlike the COAC trial that I mentioned, they only looked at shockable rhythms. These patients, they looked at both shockable and non-shockable rhythms for the initial in the initial arrest. And for the exclusion criteria, they did not include patients who had STEMI or left bundle branch block on their EKG. They excluded patients with cardiogenic shock, electrical instability, or patients who had an obvious extracardiac etiology for the arrest. So like frank hemorrhage, significant CNS injury, trauma, these patients were not included. They also did not include patients who underwent an in-hospital arrest. And in the immediate angiography group, these patients were transferred to the cath lab immediately on admission, whereas in the delayed group, they were first transferred to the ICU. And if the likelihood of ACS was actually deemed high, they could proceed to angiography, but had to have a minimum delay of 24 hours. And in both groups, revascularization was to be attempted if a culprit lesion was identified. So this table just has the baseline characteristics of these patients. And as you can see, they're fairly well balanced. So in the immediate angiography group and the delayed group, the median age was 69 and 71 respectively. About 30% of both groups were female. The average BMI for both groups looked to be around 26. And similar comorbidities, which are the usual culprits: hypertension, diabetes, smoking, dyslipidemia, with 34% of the immediate group with coronary artery disease already, and 40% of the delayed group with CAT. So, and this basically characterizes the arrest itself. So you can see here in about 91% of the immediate group and 87% of the delayed group, the arrest was actually witnessed, with 57% of that immediate group with receiving bystander CPR and 60% in the delayed group receiving bystander CPR. Shockable rhythm was noted in 52% of the immediate group and 58% of the delayed group. And importantly, the median time from arrest to ROSC in both groups was about 15 minutes. They also looked at the median GCS scores for both groups, which was 3. So again, this is a comatose population. And then the median EF for both cases was around 45% for both groups. Similarly, the pH and lactate I want to draw attention to, since we do have data to suggest that pH less than 7.2 is a poor predictor of, is basically associated with worsening mortality in these cases. And lactate greater than 7 has been associated with worsening mortality in these cases. So here in both groups, we see an average pH around 7.2 and average lactate around 5. And then in terms of the prevalence characteristics and treatment of CAD in both groups, they performed angiography in 95% of the immediate group and 62% of the delayed group, with the median time from arrest to angiography in the immediate group being 2.9 hours. The delayed group, it was a median time of 46.9 hours. And then in terms of culprit lesion, so this is actually higher, surprisingly, than what the COAC trial found, but they did see culprit lesions in 38% of those patients who underwent immediate angiography and 43% in the delayed group. And this graph is looking at the primary endpoint for the study. So again, looking at the 30-day all-cause mortality. So on the x-axis here, you see the days going up to 30 days, and on the y, you see probability of survival. And in the blue line, we have the delayed or selective angiography group, and in the red line, we have the group that received immediate angiography. And as you can see between these two groups, they noted a hazard ratio of 1.28. So basically no significant difference between these two groups. And actually, the secondary endpoints that they looked at included MI, severe neurodeficit, and then a composite of death from any cause or severe neurodeficit. They actually found a slightly higher risk for patients who underwent immediate angiography as far as that composite of death from any cause or severe neurodeficit. They did not really see any significant differences in their other secondary endpoints of rehospitalization for heart failure, and then the median peak troponin and creatinine values for these patients. And then looking at this subgroup analysis, they actually did not see any differences between the groups when they were stratified by age, whether or not they had diabetes, whether or not the first monitored rhythm was shockable, and whether either by gender or whether they received targeted temperature management. Interestingly, also, there was no difference in the patients who received more than 15 minutes of ACLS versus the patients who had less than 15 minutes. So I want to go ahead and talk about some of the study's strengths and limitations, and then leave plenty of time for discussion about this case. So the study strengths were, as I mentioned, COAC really only looked at shockable rhythms. So this was really the first randomized trial to include both shockable and non-shockable rhythms in post-arrest patients. They also, as I mentioned before, they had well-balanced baseline characteristics between both groups. And they had a very objective primary endpoint by looking at the 30-day mortality from any cause. They had also pre-specified their secondary outcomes and safety endpoints. But some of the limitations were, I did mention it was an open label trial. So the physicians and ICU staff were aware of the treatment assignments for their patients. They also don't really capture many of the patients we see with cardiac arrest who have ongoing hemodynamic instability, electrical instability, or in-hospital arrests as well. So and then as far as the patients included in the analysis, they did have a slight drop in their targeted power just based on patients that were not included because they either withdrew consent or some of the patients actually passed before they were able to be taken for angiography. So, and then early revascularization may actually have benefits outside of the studied outcome measures of specifically 30-day mortality. So in conclusion, the study noted that among patients resuscitated after out-of-hospital arrest without STEMI, immediate angiography, an immediate coronary angiography strategy was not found to be beneficial over a delayed strategy with respect to 30-day risk of death from any cause. And these are my references. And I know I went kind of quickly through this study, but I really wanted to leave enough time for us to discuss it because I thought it was interesting to see this as like one of the first randomized studies to really show this outcome. And I want to thank Dr. McDaniel especially for going through the study with me and giving some input. But I'll leave it up for any questions or discussion.
Thank you, Maya. I'll start off with a question. I mean, you and I sort of touched on this before we started, but what do you, I mean, I just, reading, when you go through this study, like you said, the way they excluded obviously STEMI, but also electrical and hemodynamic unstable patients, you're left with sort of a somewhat selective group of hemodynamically stable patients that are not having a STEMI that had cardiac arrest. I guess it seemed like angiography was somewhat set up to fail in this study, just as a unbiased observer watching, somewhat unbiased observer looking at this trial. But what are your thoughts on sort of the goals and objectives of the folks that designed this trial?
So I agree with you. I do think I will say that when the trial was initially designed, they were working with a lot of the prior studies, really, as I showed, were a lot of registry data that suggested that immediate cath would actually be more beneficial. But I do think the design, it sort of lended itself to that group of, we're excluding, like you said, patients who are having like cardiogenic shock or electrical instability. And I think the reason for that is because it's harder to, at least in the discussion of this paper, they really talked about that those patients, it's really subjective to more of your clinical judgment. And if you see ongoing electrical instability and want to rule out ischemia, it didn't make sense for them to enroll patients in this trial. So I do think the initial design was maybe biased a little bit towards favoring a delayed strategy, but I do think that one of the major limitations is excluding that subgroup of really unstable patients who come in post-arrest, who we are the group that we often see.
Yeah, I agree. I mean, I guess what I'm saying is I would have just, based on the design of this trial, I would have been frankly shocked if the immediate angiography group in this particular study design had somehow done better.
Yeah.
It would have been shocking.
Maya Stan Sherman. Was there any mention about the medical therapy that was given during those 48 hours, for the group that didn't go directly to the cath lab?
So that's a good question. And they actually did not talk about the medical therapy at all. So, and as we can all imagine, I'm sure that was a factor that is quite variable across sites and across even from patient to patient. I think the implication, looking through the discussion of that paper, was that for patients who they had a high suspicion for ACS, they were able to, in the delayed group, they were able to treat as ACS. So presumably giving the patient antiplatelet and heparin, and then going to cath at the 24-hour mark. But yeah, I mean, that's a big, I think, gap here where they don't talk about what did the medical therapy even look like for these patients.
Thank you. Good talk.
Thank you.
Yeah, this is Neil Dickert. The one thing they do mention, just for what it's worth, is that there were equivalent rates of cooling, right? I think that it's almost 80% in both groups sort of appropriately underwent targeted temperature management and other aspects, although it wasn't super highly protocol driven in terms of the post the medical management. I guess the only thing I would say is that I think from my perspective, to Robbie's question about whether this was a sort of super selected population set up to fail, this is an important subgroup of patients. It's not a I think there was a real, motivating this trial was a very real question that Maya, I think you did a nice job highlighting, that in registry data that if we don't look, we miss a coronary disease. So I think that, I don't think people are shocked that the trial was negative, but I do think it's really helpful. And I do think it's a population of patients that's not small. I think this is a lot of out of hospital cardiac arrest. And when you add this together with COACT, I think it's a pretty reassuring. It'd be nice if we had something to make this population better. I guess if we knew something was helpful, but it's reassuring that we don't need to rush to take these people to the cath lab pretty quickly. I do think it's been impactful in that respect.
Thanks, Dr. Dicker. And yeah, I think it was, they cited anywhere from like 60 to 70% of out-of-hospital arrests without STEMI on their post-Rosky KG. So it does, I think, capture a decent sized group.
Maya, what do you think accounts for the almost statistically significant better performance of the group that did not have to go to the cath lab quickly? And I think the authors sort of maybe alluded to that a little bit in their discussion, but what do you think accounts for that not statistically significant difference, but almost statistically significant difference in the groups?
Yeah, so I think they really talk about just having that extra time to do a more thorough workup of alternative etiologies for the arrest. And I think when we think about the patients we see, if we have time to make sure that they're, look for any other causes on their CT scan, get a good echo, look at what are the underlying metabolic abnormalities that they're having. Like a lot of these patients they actually will die from neurogenic causes or from multi-organ failure. So I think having that initial time, if we have time rather than rushing to immediate angiography, we can actually try to correct some of those underlying metabolic abnormalities, try to work on perfusing and avoiding multi-organ failure. And I think it's just the extra time to optimize a patient post-arrest and really just focusing on the neuroprotection, which the only thing we have is TTM at this point. So I think allowing them to have neuroprotection with cooling or preventing hyperthermia and targeting normothermia, I think those are the major things that can hopefully account for that difference.
Yeah, they did mention that the pretty far and away leading cause of death for folks on this trial was, like you said, was major neurologic injury. And I think that was sort of what they're alluding to, is that not having to go to the cath lab, you could really focus on earlier brain protection measures in post-arrest state. All right, well, excellent. Any other questions, comments for Maya? All right, well, thank you, Maya. And we'll let Anurag come forward here.
Thank you, Dr. Williams. Let me share my screen.
So Anurag Mehta is a fourth-year fellow in our clinical investigator track who is set to graduate here in a few short weeks, and he did his residency at UT Southwestern and will be headed off to Richmond, Virginia, the Virginia Commonwealth University, to join the faculty there as a non-invasive cardiologist.
Thank you so much for the introduction, Dr. Williams. Let me get my slides back up.
And Anurag is going to be talking about the VISION trial, looking at post-op troponin elevation patients. All right, take it away, Anurag.
Thank you, Dr. Williams, and good morning, everyone. Welcome to the Journal Club for today, and I will be following up Maya's fantastic talk with a discussion of the VISION study. This is slightly different than the usual Journal Club sessions that we have, in the sense that this is not a randomized clinical trial. This is actually a prospective cohort study, but I felt that it has implications in terms of the care that we provide to our patients post procedures done for cardiac issues. Here in the VISION study, as you can see from the title, it focused on patients who had received cardiac surgery, but I felt that this study has implications for our post-cath and PCI patients as well. And the VISION study is focusing on studying the role of high sensitivity cardiac troponin I and its ability to predict 30-day mortality in patients who have received cardiac surgery. I'd like to present a little bit of the background before I move into the study itself. And I will start with this meta-analysis that was published almost a decade ago now. And this study showed that myocardial infarction, as well as myocardial injury in patients after they've had cardiac surgery, is associated with the risk of adverse outcomes. However, a key thing to recognize is that this literature has been around for a long period of time, but there is no evidence-based threshold for cardiac troponin levels in order to identify these patients who've had an MI or myocardial injury after a cardiac surgery. But that being said, almost 4 years ago, there was the fourth universal definition of MI, which was released back in 2018. And as part of this consensus document, they recommended that increase in troponin level to a level greater than 10 times the upper reference limit of the assay that we use for troponin in a 48-hour period post coronary artery bypass grafting, along with evidence of ischemia on EKG or on echocardiography, is consistent with a diagnosis of myocardial infarction in patients who've received CABG and do not have evidence of myocardial ischemia or infarction before the surgery. Around the same time in 2018, there was a consensus statement that was released by the Academic Research Consortium 2, and they recommended higher thresholds for defining myocardial injury and myocardial infarction. Specifically, they recommended that if the post-op troponin level was greater than 35 times the upper reference limit of the assay that we use for troponin, along with the evidence of ischemia on an EKG or an echocardiogram, is consistent with a diagnosis of myocardial infarction, and a level greater than 70 times the upper reference limit is consistent with myocardial injury. But again, important to remember that these are not based on evidence, these thresholds that have been defined by these two consensus documents, and both a group of authors were cognizant of this fact. And I would like to move on into the kind of the design of the vision study, and what they had sought to do. One of the primary motives was to study and investigate this diagnostic threshold for defining a level of troponin that would be associated with adverse outcomes. The vision study is a prospective epidemiologic study in 24 hospitals based out in Canada, US, UK, Russia, Italy, Hong Kong, China, Brazil, Malaysia, Spain, Australia, and Poland. And patients were recruited over a period of 6 years between May 2013 and April 2019. High sensitivity cardiac troponin I levels were measured using an assay which has been designed by Abbott. And the upper reference limit for this assay is 26 nanograms per liter. And the limit of detection for troponin I using this high sensitivity assay is 1 to 2 nanograms per liter. So similar to the high sensitivity troponin assay that we're using in our practice here at Emory as well as at Grady. As part of the study, patients had troponin levels measured before the surgery, within 3 to 12 hours post-op, as well as on days 1, 2, and 3 after surgery. Important to remember that not all patients had all of these measurements kind of drawn. The median number of measurements that were performed for each patient was 4. And as you can see here, people could get up to 5 measurements before surgery, 3 to 12 hours post-op, and on days 1, 2, and 3 after the surgery. Cardiovascular risk assessment in these patients was performed using the Euroscore 2, which is a composite measure that uses 18 variables that have been shown to be associated with the risk of adverse cardiovascular outcomes in patients who are receiving cardiac surgery. And the primary outcome of interest was time to death within 13 days of surgery among study participants. Here is the list of the inclusion and exclusion criteria. As you can see, this was a convenient sample of patients from the 24 different hospitals that in the different countries that I mentioned just a couple of minutes ago. Patients who were receiving an isolated pericardial window or pericardiectomy were excluded, and so were patients receiving pacemakers or defibrillators. Along with that, people who had experienced a preoperative MI on the day of or the day before their cardiac surgery were excluded, as well as patients who had a pre-op high sensitivity cardiac troponin level greater than 300. Similarly, patients who were receiving salvage cardiac surgery while receiving cardiopulmonary resuscitation, patients receiving a cardiac transplant or an LVAD implant, patients getting an isolated aorta surgery, and those with missing troponin and mortality follow-up data were also excluded from the study. And this is the flow chart, which goes over kind of the recruitment efforts of the team over a period of 6 years. As you can see, approximately 21,000 patients fulfill the eligibility criteria. And after excluding patients for the reasons that are listed here, the final study sample was 13,862 patients that were analyzed. As part of the statistical analysis for this study, the authors divided the study population into 2 groups. The first group consisted of patients who were receiving either coronary artery bypass grafting or isolated aortic valve replacement. And the second group included patients who were getting any other cardiac surgery or a cardiac surgery along with a CABG or an AVR. The reason why they did that is that it is well established that patients who are getting CABG or isolated aortic valve replacement are at a lower risk as compared to other cardiac surgeries. And I would also like to mention that the second group included people who were getting CABG and AVR at the same time. So the first group was a relatively lower risk for post-op adverse outcomes, and the second group was at a higher risk. The authors performed Cox proportional hazard regression analysis with restricted cubic splines when analyzing their data. And the reason for choosing this analysis was that it allows the assessment of the relationship between troponin levels and adverse outcomes at a continuous level. So they are not using any pre-specified threshold in order to look at the relationship of that threshold with the risk of adverse cardiovascular outcomes, but they are looking at a continuous analysis where the relationship of troponin and death is being studied so that they can identify a threshold that would be associated with 30-day mortality. In the primary analysis, they used log transform levels of peak high sensitivity cardiac troponin levels. And again, this was done in 2 ways. The first one was the first analysis was troponin levels within 1 day of the surgery, and the second analysis was in 2 to 3 days after the surgery. And Cox models were adjusted for Euroscore 2, which I had mentioned previously is a composite of 18 different variables that are known to be associated with adverse outcomes in patients undergoing cardiac surgery. The primary outcome of interest was time to all-cause mortality within 30 days post-op, and the threshold for high-sensitivity cardiac troponin levels within 1 day, and at 2 to 3 days post-op was analyzed using the adjusted hazard ratio of 1 in the 2 groups mentioned previously: isolated CABG or AVR and other cardiac surgeries. This table here presents the baseline characteristics of the study participants, almost 14,000 patients here with a mean age of 63. 70% were male, and they had approximately 1/3 had a previous history of myocardial infarction. And risk factors, 66% had hypertension, and then 29% had diabetes, 51% with tobacco use, and 16% had heart failure as well. And you can see the distribution of the NYHA classes. So most of these patients with heart failure had either NYHA class 2 or class 3 heart failure, and almost 4% had had a previous cardiac surgery as well. Slightly more granular data in terms of their baseline characteristics, in terms of the race ethnic makeup of the study. Predominantly 70% of the study population was white and 21% were Asian. And below there, kind of bolded here, is the fact that approximately 1/4 had an LVEF less than 50%, and 42% had an estimated GFR less than 50. A small proportion, 4%, had severe pulmonary hypertension, and the median high sensitivity troponin I level prior to cardiac surgery was 9, which is close to normal, as we know from our clinical practice as well. And in terms of the surgeries here, elective surgery in 80% of the participants, and 19% of the study participants had urgent surgery. 91% of these cardiac surgeries were performed on pump, and as you can see, isolated CABG in nearly 50% of the participants, and 13% participants with isolated CABG in this study. This is the distribution of the Euro score, which is the primary variable that the models were adjusted for. And as you can see, nearly 2/3 of the population had a Euro score less than 2%, which is consistent with good outcomes or low risk of adverse outcomes after cardiac surgery. And the graph here is from the supplement of the study. But I wanted to briefly review this because this provides us with a very nice understanding of the change in troponin levels in the study population. As you can see here on the x-axis is the time point. So pre-op, 3 to 12 hours post-op, day 1, 2, and 3 post-op. And on the y-axis are the median high sensitivity troponin levels. In the green line here are patients with isolated CABG. And as you can see, levels increased significantly in the post-op time period, and a similar situation in patients who had isolated aortic valve replacement, as well as other cardiac surgeries. But you can see that the degree of elevation post-op and the maintenance of higher levels of troponin elevation in patients who were receiving other cardiac surgeries as compared with CABG or isolated aortic valve replacement, with the lowest level being in patients who are getting CABG, and the line here in red showing isolated AVR and blue showing other cardiac surgery, which is sort of consistent with the notion that patients who are getting isolated CABG or AVR, they have better outcomes as compared to other cardiac surgery, and this kind of tags along with the level of troponin elevation as well. And as you can see here on the right, the pre-op level for the pre-op troponin level for the entire study population was 9, but very importantly, within 1 day post-op, 98% of the study participants had a troponin level that was greater than 10 times the upper reference limit, which tags along with the consensus from the 4th universal definition of MI. Nearly 90% had a level greater than 35 times the upper reference limit, and nearly 75% had levels greater than 70 times the upper reference limit. And the last 2 thresholds are recommended by the Academic Research Consortium too. So a very large proportion of patients develop levels which were higher than the thresholds that are recommended by the current consensus documents. In the study during follow-up, there were 296 deaths within 30 days post-op, which was 2.1% of the study population. And here, using the primary analysis, each 1 unit increase in the log transformed troponin levels within 1 day was independently associated with an increased risk of death in patients in both groups, in patients who had an isolated CABG or aortic valve replacement, as you can see with the hazard ratio of 1.62, in patients who had other cardiac surgeries, a hazard ratio of 1.75. And similarly, troponin levels, log transformed troponin levels from day 2 or day 3 were also independently associated with the risk of death in patients with CABG or aortic valve replacement, as well as those with other cardiac surgeries, with a hazard ratio of 1.84 and the second hazard ratio of 2.77. The graph here shows the restricted cubic spline models to understand the threshold level for high sensitivity troponin levels. I'll start off with the figure here on the top left, figure A, where the graph is showing the 30-day mortality as a function of the peak high sensitivity troponin level within 1 day in the first group of participants with isolated CABG or aortic valve replacement. As you can see here, on the x-axis is the troponin level, and on the y-axis is the hazard ratio. And there is almost a linear increase in the risk of 30-day mortality, as you can see. But the level at which here you can see on the x-axis, the troponin level at which the line crosses a hazard ratio of 1 or null is significantly elevated. It is maybe close to 4,000 nanograms per liter, which is significantly higher than the current thresholds that are recommended in consensus documents. Figure B is another similar analysis, but here it's again in the first group of isolated CABG or aortic valve replacement, but they're using troponin levels from day 2 or day 3 post-op. Figure C is for day 1 troponin levels in the second group of patients who are receiving other cardiac surgery. And then figure D is for the second group, but troponin levels measured on day 2 or day 3 after cardiac surgery. And here are kind of the extrapolation of the data that was obtained using the restricted cubic spline models. In the first group of patients with isolated CABG or aortic valve replacement, the day 1 post-op troponin level associated with a risk of mortality that is greater than 1.0 hazard was 5,670 nanograms per liter, which is 218 times the upper reference limit of the assay used in the study. For day 2 or day 3 post-op, the corresponding troponin level was 1522, which was 59 times the upper reference limit. In analysis done for other cardiac surgeries, the day 1 post-op troponin threshold was 12,981, which is nearly 500 times the upper reference limit of this assay. And on day 2 or day 3 post-op, the threshold was 2,500 nanograms per liter, which is nearly 100 times the upper reference limit. So as you can see, the high sensitivity cardiac troponin I threshold associated with the 30-day mortality is substantially higher than consensus recommendations from the fourth universal definition of MI, as well as from the Academic Research Consortium 2, which kind of puts us in an area where high sensitivity troponin assays are being utilized in so many hospitals across countries, and highlights the need for perhaps refining these thresholds and the way we use them to guide our clinical decisions and patient management decisions. This study has some limitations, and I wanted to bring up some implications. The first major one being a lack of external validation beyond this cohort. And very importantly, the study did not assess the evidence of ischemia based on EKG or echocardiography. So it's hard to tease out post-op myocardial infarction versus just myocardial injury. And the duration of follow-up was limited to 30 days, and it is unclear what are the long-term implications or the long-term relationship of post-op troponin release with poor outcomes beyond 30 days. And the reproducibility with other high sensitivity troponin assays from other manufacturing companies or high sensitivity cardiac troponin T assays has not been studied as well. And in terms of the implications, I wanted to open the discussion for everyone else in terms of interpreting this data after cardiac procedures. Here it was just cardiac surgery, but also how we interpret data post percutaneous coronary interventions or heart catheterizations. And also yesterday I was in the echo lab with Dr. Dickert, and I was thinking about this. Is there a need for a study for more contemporary data in patients who are post PCI? And this would be highly perhaps relevant for a high volume center like us, where we have so many patients who are undergoing heart catheterizations, complex PCIs, and understanding the association of troponin levels and identifying thresholds that are meaningful in terms of finding the right threshold for our patients for post-procedure MI or myocardial injury. And that was all. Thank you so much for your attention, and I'm happy to take any questions.
Thanks, Anurag. Very good review. I guess for the other cardiac surgeries, you mentioned a lot of them were CABG/AVRs. I can't remember, did they break down sort of the other, obviously probably a lot were mitral valve surgeries? And,
that's right. They don't.
Okay, so just
Yeah, I looked through.
probably a mix of
Yeah,
cabbage AVRs and cabbage MVRs and things,
that's right.
and plain MVRs, I suppose, or mitral.
Yeah, I was curious about that as to what kind of surgeries they were doing, but they didn't in the appendix as well. They just said that, both happening together, cabbage and AVR, cabbage and, MVR or an isolated MVR, etc. But they didn't give a breakdown as to, nearly half of the studies were, or 40% of the studies were other cardiac surgeries, but they didn't do a breakdown.
It's just interesting. I don't know how much, in other parts of the world, they're doing isolated mitral repair surgeries. I'm not sure I would have, that's not one you typically think of as a higher risk procedure, and like that's sort of why I'm asking, it's probably not of super relevance to the study, but, an isolated mitral repair without cabbage or replacement or anything else is usually, sort of not thought of as a higher risk procedure. So how many of that group and whether that's going to sort of skew things potentially, I don't know. And I guess my other thought was, so this is clearly just looking at predicting mortality, but not necessarily not something to be interpreted as a threshold for intervention, right? I guess that, you don't want to, I don't know, confuse those two endpoints. Like you could, if you're checking troponin in a post-cabbage patient, even if it doesn't quite reach 100 times the upper limit of, you still might be interested in assessing coronaries, post-op, that sort of thing, i.e. taking them to the cath lab, things of that nature, even if it doesn't necessarily predict mortality. But just your thoughts on sort of that, like,
exactly major limitation.
Yeah, exactly.
Dr. Williams, major limitation of the study, they did not delineate injury from myocardial infarction. Looking at signs of new ischemia, they don't comment on that. Looking at new wall motion abnormalities on echo or new findings on an EKG or other evidence of electrical hemodynamic instability that would prompt us to do a repeat coronary assessment. I think that was a major limitation of this current study.
Yeah, and this is Neil. Just to sort of add to that point, and they're very upfront about the fact that they can only look at certain kinds of outcomes and not others, right? 30-day mortality is not the only thing that we're thinking about when deciding what to do in a patient who's got an elevation in the troponin post surgery or PCI or whatever the procedure. The other piece that I'd be interested in whether you think there are ways to think about getting at, they obviously couldn't, but related to Robbie's question, it's hard in an observational data set like this to look at this, but what triggered reactions, right? So they're looking at the sort of 30-day outcomes, but some of these may have they had to go back to the OR, or they had to go to the cath lab, or some of these, there were reactions that happened in some cases and probably not in most. But that's the other piece that makes it difficult to kind of sort this out is the management could have potentially been influenced by these values, and it doesn't necessarily give us guidance about that. That's sort of I guess be interested in your thoughts, but it seems like that's an important next step too, is to see the impact of these on management.
Yeah. That was sort of what I'm saying too, is that like, just, they're going to have very high very high thresholds in terms of impacting mortality, but that doesn't mean you should just necessarily ignore a troponin that's 80 times the upper limit of normal, in someone who's day one post-cabbage.
So the NEAT study, Dr. Dickers and Dr. Williams, was that patients, healthcare providers, and data collectors were unaware of the results of these troponin tests. So, the management of patients was not, biased or influenced by these super high levels. So they kind of proceeded with care of these patients, regardless of elevation or, the degree of elevation or troponin levels, which I felt was, I completely agree with both of you. Like we in real life, we would not ignore like a troponin of 12,000 in somebody who's post-op or post-PCI. But with this study, these people were not aware.
Yeah, just to clarify, and again, this is not having sort of read the paper in detail. Maybe you can help me with this. I take it that's the study dictated labs, but they could have been obtained independently, right? So if I have a patient who's in this cohort, they're going to get the troponins monitored per the study, but there also could have been clinical indications for getting it, and they wouldn't have stopped that.
Yes. So I think so they don't. I guess Dr. Tickett comment into that granularity. All they list is that patients, providers, and data collectors were not aware of the results of the high sensitivity troponin, but I am not I'm unclear regarding the granular data as to if, for example, my patient is not doing well and I want access to their troponin data, if that was available or allowed, or they used the conventional troponin assay,
right.
That was available at the different hospitals that were included in this study. And that would change management, like you mentioned, that would influence management.
All right, well, great. Thank you, sir. Well done.
Thank you.
Good review. Thank you, everyone, for tuning in today, and I look forward to seeing everybody next Friday for our last Friday morning conference of this academic year.
The preceding program is copyrighted by Emory University.